for another journal club of ours. For the newcomers, we do this every month. One interesting article we try to discuss, and everybody is welcome to contribute. Anybody can. Hello. So
how the anastomotic site it will be? I'm worrying more, ma.
நான் மியூட் பண்ணிட்டேங்க மேம். ஒரு டாக்டர் இது ஆன்ல இருந்துச்சு, ஓபில இருக்காங்கன்னு நினைக்கிறேன். உங்களுக்கு மியூட் பண்ணிட்டேன்.
கட் பண்ணிட்டாங்க, அது மட்டும் தெரியுது.
Shankar is getting all excited. Whoever that is, try to talk to Shankar, okay?
Okay.
Okay, so welcome to all of you again, and Madhu, you can start.
Yes, ma'am. Good evening, everyone. It is my privilege to introduce our moderator, Dr.Gnanasanker Natesan. Sir needs no introduction. He is the past president of Obstetric and Gynecological Society of Salem, and he's a renowned laparoscopic surgeon and a role model to many. He is head of the department of minimal access surgery, gynec-oncology, and reconstructive surgery at both SKS Hospital and Manipal Hospital, Salem. He's done his UG and PG from JIPMA, Pondicherry, and he's won numerous national and international awards and prizes for his lab surgeries. Sir is also the title holder for Indian Idol of Gynec Endoscopy. He is operating faculty in many live laparoscopy and colposcopic workshop and the organizing chairperson in for Salem Ops Express highlight lab series, step-by-step live and modus operandi e-workshops numerous times. Over to you, sir.
Yes, so good evening all. It's nice to be in this platform, and on a Saturday evening at 8 o'clock to see so many of you log in and then be here itself says how much you are determined and dedicated to what you do, and how interesting the topic for today is. I hope Dr. Madhu, I'm sure, is well prepared and she's all set, and there's a lot of brightness coming from her screen. Threatening கிடையாது, அவங்க எவ்வளவு பிரைட்டா இருக்காங்க பாருங்க, beaming with smile and already and the article as such is quite interesting. Only thing is just from the topic, from the speaker, and from the introduction and to the end, I personally felt there was a lot of bias. Okay, I hope I'm opening your eyes up. Biased article? Yes. So that is my personal opinion. Let us see what she is going to say, and let us all pull in our ideas and then see where we can take forward and what take-home points we can have from this 1 hour. Okay. Yes. So so happy to welcome Dr. Madhupriya. She has done her MBBS, MRCOG, and has finished her diploma in gynae laparoscopy from Germany, TL Institute, and had her fellowship from Triple. They got a lot of best accolades. I'm sure most of us are have seen her talk. She has also authored some articles in BJOG, IJCP, and IUI book co-author. What's the book name, Dr. Madhu? I'll be happy to have one. And her special interests are in the field of oncofertility and poor ovarian reserve. So the topic for today is from JMIG, the article. It's the endometrioma treating paradigm when fertility is desired. So this is a systematic review, and so we'll give the time over to Dr. Madhu, and then after she finishes, we can have a discussion over it. Madhu, you can share your screen.
Thank you very much, sir. Good evening, one and all. Thank you so much for that introduction, sir. Thank you to the moderator. Thanks, Scot-Jc Club, for giving me this opportunity to talk in front of you all august audience. The topic that we are going to discuss today is about the ovarian endometrioma, especially when fertility is desired. And the journal is the Journal of Minimally Invasive Gynecology. And the review article called The Endometrioma Treatment Paradigm When Fertility is Desired, a Systematic Review. This is by Charles E. Miller. And let us see what the journal says about. As we all know, there is always a dilemma between a surgical management or an IVF treatment when it comes to ovarian endometriosis. The treatment of ovarian endometrioma has a lot of twists and turns in its pathway: when to operate, when not to operate, when to intervene medically. Is there a role of medicines in the treatment of ovarian endometrioma, especially with infertility? Is there a role to reduce the pain? Is there a role of medicines before and after surgery? All these are certain dilemmas that goes through the treatment of ovarian endometrioma. This journal has tried actually to determine a decision tree with 7 different questions. Number 1, is there concern for ovarian malignancy whenever an ovarian endometrioma is treated? And does the patient have significant pain? So a patient who is infertile with an endometrioma with a significant pain. And is the endometrioma decreasing the spontaneous pregnancy in such an infertile patient? And is the endometrioma negatively affecting the success with IVF? And is there a risk of endometrioma rupture at the time of egg retrieval if at all the patient goes in for an IVF procedure? And does the endometrioma negatively affect the antral follicles on the affected side in comparison with the non-affected side? And does this endometrioma increase the risk of implantation failure? These are the 7 most important questions based on which the author and his team has actually decided about the decision tree to give us an idea of step-by-step approach towards an ovarian endometrioma. As we all know, ovary is always something that do not give us a second choice. So treatment of an ovarian endometrioma needs to be taken always with caution. In this journal, they have tried to strike a balance between treatment of ovarian endometrioma in patients with infertility, where insufficient surgical treatment might lead to increased recurrence, while overzealous treatment may result in decreased ovarian reserve, obviously due to the cortical follicular loss. So how valid is this review article? They have actually had identified so many number of records, but after screening and removing the duplicates and identifying the eligibility criteria and adding the inclusive criteria, they were able to identify 59 good articles, the studies which they have included in the meta-analysis. They have also taken the final words from the 48th Global Congress of American Association of Gynae in 2019 and the 5th edition of the Endo Dubai Congress in February 2020, along with the medical literature. Let's go through each question one by one. The first question is there a concern of ovarian malignancy? Whenever a ovarian endometrioma needs to be treated, then an underlying ovarian malignancy makes it faster. So normally an endometrioma is identified using a high sensitivity technique, the transvaginal ultrasound, because of the ease of access and the higher sensitivity of detecting the ovarian endometrioma. And as we all know, the ultrasound pattern of recognition says that the most common low-level internal echoes called the ground glass appearance, the homogeneous hypoechoic appearance of the internal milieu, the echogenic foci that can be seen at the borders, and with no internal Doppler flow suggests that it is ovarian endometrioma that we're dealing with. We have got IOTA analysis, the International Ovarian Tumor Analysis Classification, which were able to identify a unilocular, a cyst with less than 7 millimeter solid components, or those with largest diameter of less than 10 centimeters with a good color flow but no vascularity, no strong blood vascularity present within the cyst as benign, whereas those with very strong blood flow or with irregular multilocular solid tumor greater than 10 centimeter, or the presence of ascites, or the presence of papillary structures more than 4, or an irregular solid tumor were considered as malignant ones. This IOTA scoring were based on the study wherein 1,066 patients out of 1,233 patients having persistent adnexal tumors were evaluated using 42 variables on a grayscale ultrasound, and 6 Doppler variables were involved, and they evaluated to see which out of these variables had a higher predictive value for a malignant tumor and that for a benign mass. And this led to the formation of the rules, M rules and the B rules in the IOTA, and they were able to identify 27% of tumors becoming malignant from these, and 73 were benign. This formed the basis of the IOTA rules, which is the most commonly used classification nowadays to differentiate the benign and the malignant ovarian cyst. Now, this will help us to define that it is only an ovarian endometrioma or the one with high malignant potential underneath. Though these 10 simple rules will help to identify the underlying malignant potential, we need to be aware that it is applicable to only 76% of the tumors, and that the sensitivity is only 93%, though it is on the higher side compared to the other classifications and rules, and a specificity of 90%, with a positive predictive value of reasonable 80%, and a very high negative predictive value that helps us in identifying the malignant potential, 97% negative predictive value. Though the best is yet to come, this is the most important classification that helps us to identify the underlying malignancy. Now, time and again, various case control studies have proven that there is a higher risk of underlying clear cell cancer, endometrioid cancer, or low-grade serous cancers when there is a ovarian endometrioma, but there is no such high risk of mucinous or high-grade serous invasive ovarian cancers or borderline serous or mucinous type of ovarian malignancies. 13 case control studies have evidence that there is a significantly increased cancer risk underlying the ovarian endometrioma. The American College of the Obstetricians and Gynecologists says that in case of an ovarian mass where a premenopausal lady with elevated CA-125 levels, or when the ultrasound shows features suggestive of malignancy, or there is a high IOTA scoring, then a gynecologist needs to be involved. And they also suggest cryopreservation of the egg or the embryos, especially when the recurrent potential of the ovarian endometrioma is seemingly high and if the present ovarian function is well maintained. The question number 2 in the decision-making tree is if the patient has significant pain. Subfertile patient with ovarian endometrioma with pain, which can be a chronic pelvic pain or deep dyspareunia when the uterosagal ligament gets involved, or it could be a dysmenorrhea, which is deep when the intestines are involved, or it could be a lower urinary tract pain-like symptoms when the vaginal area is involved. So, from the studies, we understand that the pelvic pain is proportional to the coexisting peritoneal lesions, and we see the pain in 85.4% of women with ovarian endometriomas who have an associated peritoneal lesions, whereas those with no peritoneal lesions, only ovarian endometriomas, we can see that about 38.3% only had pain, which says that there is a massive difference, and those with peritoneal lesions exhibited pain as well. Coming to the surgical management of endometrioma, cystectomy is often voted better than the fenestration coagulation group, which is a conservative group, because there is low symptom recurrence with cystectomy, there is low reoperation tendency with cystectomy, and there is a greater pain improvement in patients with dysmenorrhea or dyspareunia or a chronic pelvic pain when cystectomy is done. As far as the role of medical treatment in endometriomas are concerned, the quoted studies suggest that there is no role in treating the existing lesion, but medical management can be considered to mitigate the recurrence of ovarian endometriomas and to decrease pain in case there is a cyst of more than 4 centimeters size. It's important during surgery not forget that the excision of small endometriomas, which they mean as less than 3 centimeter size, do not decrease the pain complaint in the patient in most of the cases. So they suggest to avoid aggressive stripping of the cortex from the small endometriomas, and they also suggest a pre-surgical freezing of the oocytes and the embryos to be considered. The question number 3 out of the 7 questions in the decision tree is the endometrioma affecting spontaneous pregnancy rate? There are many studies time and again, apart from those quoted from this journal too, that endometrioma affects the spontaneous pregnancy rate, and the cumulative pregnancy rate after a cystectomy is seemingly high. Here they talk about a spontaneous normal pregnancy rate and not the ART or the IVF. The use of either a cystectomy with the principles, the surgical principles being followed, or a plasma energy have been found to give similar pregnancy rate as per the studies which have been quoted. Coming to the question number 4, whether the endometrioma negatively affects success with IVF, there are no second thoughts because many of these studies have suggested that yes, endometrioma negatively affects the success with IVF treatment. How does that happen? Because endometrioma leads to decrease in the number of follicles above 16 millimeters, which decreases in turn the number of retrieved oocytes, decreases the number of matured oocytes, number of implantable embryos formed from them, the implantation rate, and after surgery, even the decrease in the AMH levels contribute to a decrease in the IVF success rates. Whether a surgery is done or simply because of endometrioma pre-surgery, there is a decrease in the IVF success rates. Significant decrease in the AMH is identified in those with bilateral endometrioma, either prior to surgery with size greater than 5 centimeter or post-surgery, because a good chunk of the tissue with the ovarian cortex gets removed when a large endometrioma gets removed, especially when it is bilateral. This is again suggested by various studies, the main being the Horace Romans, which says the direct proportional relationship between the endometrioma size and the ovarian parenchyma, which is removed during cystectomy inadvertently. Even after a cystectomy, those who have had ovarian endometrioma still have a decreased ovarian reserve mainly due to the 4 reasons quoted. 1. Due to removal of the normal ovarian cortex during the surgery. 2nd, due to the thermal damage, inadvertent thermal damage to the ovarian parenchyma, thermal damage that could happen to the ovarian vasculatures, and due to the inflammation secondary to surgery, though that is considered the minimum. Now, the size of endometrioma is proportional to the ovarian parenchyma which gets removed inadvertently at surgery. And this is found that it is 10 times the normal ovarian tissue that gets removed during the removal of the endometriotic cyst when compared to the other ovarian cysts, which is pretty higher. And hence, younger women with small endometriomas but severe excision that has happened leads to even greater follicle reduction because of the cortical follicle loss. So, such a great concern to have in young women with even small endometriomas that are excised. Is cauterization the enemy then? Seems so. There is a decline in the AMH post-operatively, which was comparatively high with cauterization, especially the monopolar cautery compared to bipolar, but cautery as such when compared to suturing, hemostatic sealant, plasma energy or laser vaporization, and even the ethanol sclerotherapy were studied and suggested that yes, it seems that the cauterization is one damn enemy against the follicular loss. What about the conservative management of ovarian endometriomas and when to indulge into IVF along with a conservative management? The studies here quoted shows that when endometriomas are small, that is less than 3 centimeters, there happens to be decrease in the number of oocytes, number of mature oocytes, total good embryos formed, total good quality embryos formed, implantable status of the embryo thus formed, and the clinical pregnancy rate when they are removed by surgery than when compared to conservative management. So, in those endometriomas of ovary which are less than 3 centimeters, they suggest conservative management and IVF, and in the present scenario, to avoid a surgery. Found anything between the conservative management and surgical treatment of endometriomas more than 5 centimeters? Yes. They found that after surgery of an endometrioma more than 5 centimeters, there is a faster progressive AMH decline, a loss of follicular density because of stretching of the cortex, and that the amount of ovarian parenchyma removed is proportional to the size of the endometrioma. So, bigger the endometrioma, higher will be the stretching of cortex, more will be the ovarian parenchyma that is removed, more will be the follicular loss. And the focal inflammation that happens due to fibrosis because of endometriosis and because of the surgery, and an increased oxidative stress incidentally, which leads to a decrease in the AFC later. But what is the outcome that they have observed? Comparing the conservative and the surgical management in smaller endometriomas, the live birth rate, the clinical pregnancy rate, the miscarriage rate, cycle cancellation rate, and the follicle production rate have remained the same, though there has been a decrease in the antral follicle count, the eggs retrieved, higher doses of gonadotropins needed to produce good quality oocytes after surgery. The excision of endometrioma, especially in a bigger ovarian endometrioma, can have an advantage of reducing or reversing the inflammatory actions or the pro-inflammatory cytokine induced fibrosis or oxidative stress. Am I audible?
Yes, sir.
Thank you so much, sir.
Yes.
So, coming to a conclusion that they say for the present scenario, comparing the surgery and the medical treatment and the conservative treatment, there is no consensus that there is a necessity to excise the endometriosis before going ahead with an IVF. This stands true especially for smaller endometriomas in younger women. This is not a status quo, and there may be future studies which they quote that they can compare the non-treatment with the surgical treatment of endometriomas more than 3 centimeters size without a bipolar use or the cautery, which is seemingly the foe, and show the advantage of surgery in treating endometriosis. The next question in the decision-making tree is if there is a risk of endometrioma rupture at the time of the egg retrieval. Now, an incomplete follicular aspiration is seemingly 3 times higher depending on the size and the position of the endometrioma during the egg pickup. There is a chance and a high risk of accidental contamination of the follicular fluid with the endometriotic fluid. There is an increased risk of rupture of the endometrioma during the egg pickup. The main factors contributing to this is the size of the endometrioma and the position. The way they are positioned, the way they are increasing in size, that leads to increase in the risk of all these 3 factors. In turn, this leads to decreased fertilization rates, decreased pregnancy rates, with increased pelvic infection and abscess rates. Are my slides moving? I'm so sorry.
You're trying to move now?
Yes.
No.
I'm stopping the share screen. Sorry, everybody. Sharing the screen again. Is it visible, please?
Visible, but it is from the first slide.
Yes. I'll move it down.
Yes.
Yes.
So, the question number 6 in the decision-making tree is if the endometrioma negatively affects the antral follicle count on the side where the endometrioma is present in comparison to that on the unaffected side. The answer is yes, and it is blatant that there is a decreased AMH and the antral follicle count on the affected side, and a decreased median number of oocytes that are retrieved from the affected side, and a progressive decline in the ovarian reserve over time, and also at 6 months post-surgery and further. And it is also suggested that cystectomy prior to ART is advised in 2 conditions. One out of that is when the antral follicle count is low on the endometrioma side, and it seems that there is an increase in the antral follicle count or the visibility of the antral follicle count, and a reversal or reduction of the inflammatory factors due to the endometrioma that happens after the surgical cystectomy. So does the endometrioma contribute to the implantation failure? Here, we suggest RIF, the recurrent implantation failure, and recurrent pregnancy loss put together, giving the implantation failure. They have found out that the embryos formed out of the donated oocytes from the donor having endometrioma have also given a decreased implantation, and the endometrioma disrupting the endometrial normalcy and receptivity has also been another contributing factor for decreased implantation. So this has been studied by various papers which have been quoted in this review article as well. What are the mechanisms by which the damage usually happens? As we know, one is through the inflammatory mediators, the pro-inflammatory balance on the higher side and the anti-inflammatory balance tipping downwards. The chances of progesterone insensitivity or increased cell proliferation and increased estrogen receptors because of the P4 insensitivity, and defects in the decidualization that happens because of the P4 hormone insensitivity leads to a pro-inflammatory phase inside the pelvis. So whether this surgical removal of the endometrioma is able to reverse such inflammation is still a dubious call to take.
Madhu?
Ma'am, I'm there, but the slides are not moving again. I'm so sorry. Just getting to the last slide.
No.
So the paper totally has come to a conclusion with a decision tree from all these 7 questions, suggesting us that if a patient with subfertility with the ovarian endometrioma comes, we first think if there is an inherent malignant potential. If yes, a oophorectomy is suggested or a ovarian cystectomy, depending upon the type of malignant potential that the ovarian endometrioma has. Prior to which, an optional egg or embryo freezing, the cryopreservation strategy is suggested. That's a new welcome thing which we are able to see in this decision tree on the whole. And in case there is no malignant potential, the second question comes whether the patient has pain. If the patient has pain and if the size of the endometrioma is more than or equal to 3 centimeter, then a surgical management is suggested, which is ovarian cystectomy, prior to which a oocyte or embryo cryopreservation is optionally suggested too. If the patient has no malignant potential, but there is no pain as well, and the size of the endometrioma doesn't matter. When the patient has pain and the size is less than 3 centimeter, we try to ponder if there is any medical management that is possible for pain relief at that point. If there is pain relief, it is better to go ahead with a oocyte or the embryo cryopreservation before the fertility treatment. If there is no pain relief, then surgery is suggested as a part of pain relief after cryopreservation of oocytes or embryo. If the patient has no malignant potential, no pain, but has infertility, then size does matter. If she has an endometrioma more than or equal to 3 to 4 centimeters, surgical mode is on again, before which an optional egg or embryo freezing is suggested. But when the size is less than 3 to 4 centimeter, it is better to attempt a spontaneous pregnancy without going in for ART. Whereas if there is no infertility, she is not planning a fertility at that point of time, then an optional egg or embryo cryopreservation as a prophylactic mode is definitely suggested. If in case the person who was trying to get pregnant conceives spontaneously, well done. If not, then assisted reproductive techniques are introduced. Before going in for the assisted reproductive techniques, there are 2 places where ovarian cystectomy is suggested prior to assisted reproductive techniques as per this decision tree? Number one, when there is a high risk of rupturing the endometrioma during the egg pickup, and there is a high risk of having an ovarian or a pelvic abscess. And the second is when there is a very low antral follicle count because of the large endometrioma, which is a space occupying lesion. Then, even before an ART procedure, ovarian cystectomy is suggested, following which assisted reproductive techniques are suggested. While going through the assisted reproductive techniques, if there is a chance of implantation failure, then an ovarian cystectomy, if not done earlier, is suggested. For example, if there is associated adenomyosis, associated big, larger endometrioma, then yes, the ovarian cystectomy is suggested at least before the embryo transfer, because the studies quoted here suggest that there is a decrease in the implantation, decrease in the endometrial receptivity, even when the endometrioma is present after the egg pickup. If there is no implantation failure expected, assisted reproductive technologies are proceeded with, that is the egg pickup, following which embryo transfer is done. So to conclude the decision-making tree, it gives an update to the present scenario with the available meta-analysis paper, though not much of randomized control studies have been included in the systematic review or in this review article. Secondly, they also have a gray area where they say that not always does this status quo remains, and this can be changed depending upon the developments in the science and technology that comes up in the future. Thank you very much for the wonderful opportunity, Scot-Jc. Thank you so much to everybody. Any questions from the moderator, from the audience?
Yeah. Dr. Madhu,
Hello, sir.
really heartfelt congratulations. It was such a clear presentation. I think even better than listening to Charles Miller himself.
Thank
He
you
himself
so
might
much.
be
That made my
envious
day.
that somebody has gone through the paper so well and presented it so well. Yeah, so really heartfelt appreciation. I will leave the session open for people to put in their ideas before I can add a few of mine own. First is definitely we need to commend the author for the work he has done. Among the three types of endometriosis, I think this is something which is really juggling between the surgeons and the infertility specialist. He has done a lot of work behind for providing a general and a simplified algorithm. I think that's very simple. This is very easy for anybody to understand and then just have it in the back of their mind. But day-to-day practice, when we sit in front of the patient, things are more complex. It doesn't just only with the 7 questions. I don't think we'll be able to come to a conclusion as to what we need to do, and we might have to individualize our approach case by case. As I said earlier, throughout I was seeing a slight surgical bias, which I also will agree. Because being a surgeon ourselves, I was finding in a lot of areas where he had surgical nature. He himself, I think, author himself is from a surgeon background, Department of Minimally Invasive Gynec Surgery, where we believe instead of sitting and hovering and hatching over, cut clear, solve the problem, and then move forward. That's a typical surgeon's attitude. Often areas you find, I think it was somewhere in question number 3, where he said that no medical therapy is effective in treating existing endometrioma. I felt that is quite a daring statement when he said that no medical therapy is effective, because that was question 2 when he was answering. where people all would strongly disagree, and then they say that no, there are enough number of medical therapy when the patient is particularly not keen on pregnancy. And often you find many papers where he refers to, and he himself says, where surgery increase IVF outcome, surgery decreases RIF chances. So they're all, I felt that there is a slight surgical bias. That is just my personal observation. Another thing that I observed was very liberal resort to oocyte cryopreservation. This I don't find very often. Almost for every question you see that you want to go for surgery, don't worry, you got a oocyte cryopreservation. Do that, then proceed with surgery. That was one observation. What else? Yeah. So you can add your questions. Let's have a discussion, and after which I can have some final points from my side. Vani ma'am?
Yeah, excellent presentation, Madhu. It was so nice. Meticulously you went through all the questions. Anyway, Shankar told you about it. Yeah, I really like this article. But actually, I thought despite being surgeon, he tried his best to be, as non-biased as possible. And actually, if you look at the algorithm, finally, unless you have cryopreservation, don't touch the patient. That is how it is. That's the inference we get if we just look at the last thing. But he really looked at a few aspects of whether to do surgery or not to do surgery. I really liked like small because now the pendulum keeps swinging in all the problems, not only endometriosis. Wherever you take anything, you take pendulum keeps swinging as we accumulate the knowledge. We go this way and we accumulate more, come back this way, and then it keeps happening. But now I think currently we are in a state where endometriosis is supposed to be a chronic inflammatory disease, and it is a disease where there is an estrogen excess, progesterone resistance, and to remove that chronic inflammation, it is very, very difficult. Whether we can suppress all that chronic inflammation and suppress progesterone resistance just with your medication, we don't know. And if we are going and operating, if we are doing a half and half operation, whether we are achieving the success, that is also a problem. So if you remove the disease completely, of course it is like a cancer. No, whatever you are seeing, you are removing. There can be something which is not there as well. So again, getting a very good clearance, it's almost impossible. So there are so many things which are coming up, but on the whole, it is generally agreed now I think currently, according to my understanding, that if you can remove significant part of the disease, you can reduce chronic inflammation and thereby increase the quality of the oocytes and thereby increase endometrial receptivity. This, I think, right, for today's understanding, I agree strongly, but major concern is losing the follicles. And I think they have guided us properly here. Younger women, lot of follicles available. Don't worry, don't go and remove the disease. Just take the follicles, make embryos. You will get some embryos which are quite good. And then if you think that there is chronic inflammation going on and there is a lot of pelvic endometriosis, then go ahead and go remove the disease and then go transfer or something like that. And if it is, the one important point he mentioned is, if the endometrium is on one side and the other side your AFC is very good, and the side where endometrioma is there, AFC is very less, then it is clearly showing that endometrioma is the cause for suppressing that ovary. Then in case if you go and remove that endometrioma from that ovary, you are, that is one clear cut, something where he says, your AFC may improve. your AFC may improve, because that is obviously causing a lot of problem in that ovary. So like that, there is like, if I start, there is probably no stop. If I can keep going on. So those are clear-cut ideas. Younger women, smaller endometriomas and multiple endometriomas, probably better to avoid cystectomy before we get those oocytes in our hand. Even if they are bad, try to get some oocytes. Then if you think you don't have proper embryos, and if all your oocytes are bad, go ahead and do the surgery, and then go for second pickup. You can try to balance out that. Do first pickup. If you don't get proper embryos, then probably do surgery and then go for second pickup. So initially itself, if you go and remove everything and then you don't have anything to pick up, then you are really at loss. So that is one thing. And then this large endometriomas, and very low AFC, he says you go and do his cystectomy. That is one thing, is little bit, already only 1 or 2 follicles barely trying to be there and just be visible, and go ahead and remove them. A little bit difficult to digest. Maybe unless we do it and see, if we are bold enough to do it and see, and then if the follicles are remaining there, and then, or if the 2-3 months later after you do cystectomy, if the follicles become more, then that's a really good thing. Maybe we should wait for some more articles from these people. So I don't know, maybe I have confused, or
no, Miller is clear, ma'am, don't worry.
It's like it keeps flowing. Anybody else? Kanagi ma'am?
Oh my God, this is such a huge topic. Yes. And I'm sure a lot of 100 more things each one can say about this. But this being a systematic review, it's looked at certain aspects. What I think the most troublesome thing in endometriosis is recurrence. We may, I think that is a very important thing. What we may go remove and go ahead. After 3 months, she comes back with the same thing sitting there. That is one aspect we have to be aware of. And I think we have to put forth certain things which we should not do. One thing is just emptying the cyst, which leads to further big difficult surgeries, and it's very, very difficult when we just drainage of the cyst alone is done. So try to do the excision as much as possible, and especially the large ones. And regarding the size and fecundity, I think there's a whole lot of things which we don't know, because we have removed, I'm sure all of you would have removed large endometriomas, and there have been spontaneous pregnancies. So what does that size relate to fecundity? So there are a lot of things which we don't know about endometriosis. That's what I think. And I also feel that you have to individualize the treatment, whether you will remove the thing, or you will remove the oocytes, do the embryos and freeze them and then go remove, or whatever it is. I think it's a highly individualized approach we must have. And the other thing we should bear in mind is the age of the patient. Many of the spontaneous conceptions are in the younger age groups. So even if they have fewer oocytes after surgery, they fall pregnant quite quickly and quite easily. So that's what we have to bear in mind. The age of the patient, the older the patient, whatever you do, it's more difficult to get them pregnant. So these are a few things that pass. And regarding medical treatment, of course, it does not enhance for fecundity, or does not increase the results, medical treatment. It sort of keeps some things that are quiet for some time. I think that's the only place. Maybe the pain is a little less, but severe endometriosis, even the pain factor is not relieved. So I'm not much in favor of medical treatment. The other factor which is not discussed here is the adenomyosis, which may affect the implantation. It's often coexistent with the ovarian endometriotic cyst. So that also we have to bear in mind. Of course, even in such patients, I just recently had a case who had bilateral huge recurrent endometriosis with adenomyosis. And I was just wondering with pain, which got relieved by some yoga treatment. And I was just wondering what to do with her with the huge adenomyosis. She got into a spontaneous pregnancy, and now she's 26 weeks ongoing. I'm hoping that she won't have a premature labor. So these are a few of my observations. And of course, don't give up hope even with the most severe cases. We had a minister's daughter-in-law, who had absolutely a frozen pelvis, was put up for ART, and by the time she finished her the down regulation, she was pregnant. So that's another thing we have to keep in mind. These people, however severe, especially if they're young, they can have spontaneous pregnancies.
Yes.
Yeah.
Anyone else? Thank you, ma'am. That's a nice.
Madhu, congrats, Madhu. Beautiful presentation. I have gone through the article. Nobody can present this so simply and adorably. It is very nice. Vani, the large endometrioma with few antral follicle, what I understood is the other ovary, if it is normal, and the large endometrioma with few antral follicles, if we remove the cyst, as you told, we can reduce the inflammation. And even though we lose few follicles on that side, we can conserve the follicles on the other side. Number one. Two, sometimes, even if it is a very big endometrioma with few antral follicles, if you remove that, whatever few number of follicles you get will be a good quality one. Out of that, the embryos also will be good grade one. So that's what I felt. Maybe I do not know whether it is correct or not. This is regarding that large endometrioma you told, no?
If it is on one side, it is okay, ma'am. If on both sides,
Yes.
I think
both sides definitely it is definitely it will compromise the number of oocytes.
Yeah, many a times we see large endometriomas posteriorly getting stuck and kissing ovaries and
kissing ovaries, yeah.
Follicles around the cyst, and then like Kannagi madam said, there is some adenomyosis also in the uterus and question mark uterus. Everything is stuck, frozen pelvis. So you want her to get pregnant.
Totally frozen.
So that's where everything starts, and really exciting to go through the journey and then somehow get her pregnant. It is nice, but this article I think gives some insights. So some questions are answered, and initially we can filter out a few cases so that okay, this I'll do this. Right now we have an idea that if one side is good, one side there is an endometrioma, and in that side, if the AFC is less, we can definitely go and remove that endometrioma. It will decrease the inflammation and then it will improve. So some at least few pointers we got where it seems to be clear as to how to go about this large endometrioma. I think maybe according to them, if we go ahead and remove the endometrioma, there'll be some good follicles, and maybe the inflammation is also less, and then we can pick up those follicles, maybe do multiple stimulations, and then probably get her pregnant. So probably we have to look at that also. And then this big thing about oocyte cryopreservation, that is one thing I don't know how to address that. But it's good to know that we have to be all the time thinking about oocyte preservation whenever we have endometriosis, because we don't have anything to stop the disease from progressing. Shankar?
Yes. Just a couple of points from my side, particularly from the onco background, because the first question they asked itself was, is it cancer? As they are telling, this IOTA classification itself will help us a lot. It has got a good negative predictive. So if it is an obvious malignancy, it is going to say yes. But what happens when you have a gray zone once again? What I would suggest and what literatures we have is the use of HE4. He hasn't mentioned about that. HE4. Unlike CA125, HE4 is not altered by the physiologic state, menstruation, pregnancy, endometriosis, doesn't affect that. Just for viewers' use, I want to say that it is available in India. It will cost you around 3,000 rupees. I think many labs are now started doing. So when you are in a gray zone and you are not sure what you are dealing with is a malignancy or benign, so even after doing your B rules, M rules, you're still confused, go for MRI, go for HE4. In this entire flow chart he has put, you see though, it's displayed in the screen, where he says malignant potential, yes. And then he says oophorectomy versus ovarian cystectomy. Can you see just at the left corner? The thing is, whenever there's a suspicion of malignancy, there is no role of ovarian cystectomy. You cannot remove the cyst and leave the ovary behind. You have to go for oophorectomy. So that is an observation. Maybe there may be very clear situations where you see that the cyst is too eccentric. You can still try to salvage, but they are quite a rare situation. Whenever there is a doubt that it is malignancy, go for an MRI more than an ultrasound. Then go for CA125. Associated HE rise is more pointing towards malignancy. Go for oophorectomy at that point. Before that, if possible, go for egg pickup freezing. And next, one of the points that I learned, and nowadays what we do is there is no isolated ovarian cystectomy. Because mostly we do it for patients who are having pain as a symptom. As the article clearly pointed out, there will also be additional peritoneal disease. We have to address that also. We have to go for peritonectomy or ablation of the lesions along with the ovarian cystectomy. So that is something from my side I felt I wanted to add. Yeah, how common is the rupture and infection following oocyte pickup, ma'am? How often have you seen? Because most articles you see, they are all dated back to 2008, 2010. Hardly you find them now.
Yeah.
Because that has an indication to go for surgery prior to IVF. I was wondering, yeah.
Yeah, like unless we have, it's not very common, and unless we have a uterus sitting on the top, and in the posteriorly we have big endometriomas and few follicles below that. So it is so very, very difficult to reach them unless you touch them. Only if you have only 2 follicles or just 3 follicles. And when we are trying to, before we stimulate, we'll try to assess whether we can reach the follicles. We do that all the time. And if it is very difficult, then probably we have to go through it. And especially if it is a 8 centimeters endometrioma or 10 centimeters endometrioma, imagine you will be in the endometrioma, draining the endometrioma, and then you will never reach the follicle only. So I think those are the situations where you can really think of going ahead and doing a proper removal. Like Kannagi madam said, I used to think at one point maybe do a laparoscopy and drain these things, and then they get smaller, and then go ahead and stimulate and pick up the oocytes, and then do the proper surgery, and then transfer, and then have best of both worlds, have the oocytes also, and then remove the inflammation also before you transfer. So that was my understanding just a couple of years back or 1 year back also. But nowadays, after going through all this, probably we can remove the cyst and then still expect some follicles there. What do you say, Shankar? What do you
Yeah, true, ma'am. Actually, regarding the size also that you are talking, no, What this article says is very early, small endometriomas, you try to strip off, you remove a lot of follicles.
Yeah.
That's, I think I also would agree with them. Just like what Madhu also was presenting, after the endometrioma forms, it takes some time before it is walled off clearly. So getting a plane becomes difficult if you start touching smaller lesions because they're too early. Over time, I think it gets tried to wall off and it becomes easier. And the longer it stands, more hemosiderin exposure, more cytokine exposure, the larger it becomes, I think more damage. So that is where he comes back and says, if it is too large, you remove it. Maybe you will decrease the inflammatory response and improve your outcome. So very early, don't touch, and very large, I think he is more towards removing and decreasing the inflammatory insult. I think we had a good discussion. Anybody else wants to add? And Madhu, do you want to add any concluding thought?
Shankar, just a small
Yes,
interception. This is regarding the question of infection following
Yes.
when you do along with the cyst. I've had one occasion where there was a recurrence, huge recurrence, 5 centimeter, and there were hardly any antral follicles on either side. And when we went and did the aspiration from the non-affected side, still she went in for something like an inflammation on the affected side. That was one thing. So it doesn't, I don't know how, perhaps the way we approach through the vagina may bring in the infective element easily. That was number one. The second thing was another, as you said, as Vani pointed out, I had a patient who had a large endometrioma and the other ovary was almost gone. So I had to deal with only 1 or 2 follicles, antral follicles I could see just beyond the endometrial cyst. And we managed to get it. But all along, I was going on assessing whether I can approach that follicle without touching the endometriosis. And when they enlarge, it is quite possible to do it, but keep assessing it. That was another observation. So we got the oocytes from those follicles, and luckily she fell pregnant.
Maybe we should think of abdominal pickup also.
That might be even more messier because we don't know.
The follicles are not approachable from below. From above, if we can pick up 1 or 2 follicles. I mean, just thinking, I've not done that so far.
I have been to Dr. Horace Roman, France, where he tries ethanol sclerotherapy for very large tumors. So aspirate and in the same setting put in ethanol sclerotherapy. Actually, that paper also is quoted in this in this review. Yeah. So maybe we can try it out and then see what happens.
Few people are doing in India also.
Sanjeev has done some paper, I think. So Ramchandra, I think they published a paper on that, ethanol sclerotherapy.
Particularly in the recurrent setting, probably, ma'am. Recurrent setting and with the poor reserve, instead of re-cystectomy, we can think. So in general, from this article, I think it goes like this. Whenever there is suspicion of malignancy and when pain is the predominant symptom, maybe rapidly growing, think about surgery. When the ovarian reserve is poor, when it's a bilateral one, and previous interventions, try not to touch with surgery and think of early fertility. So that's what we practice. I think it appreciates what we are doing correct. Quite a few learning. I thank Vani ma'am, Dr. Madhu, excellent work. And Kannagi ma'am for putting in all your ideas. Thank you all. How about enjoying the Saturday evening? Vani ma'am, shall we or you continue talking? I don't know how long you keep talking.
I am not going to talk, okay? No, you just said, enjoy. Na? You all this time you were suffering, so now you want to go and.
Oh, no.
Okay, I will set you free. You go and enjoy. Okay, thank you very much.
Yeah.
Thanks.
No, because everybody is still logged in. It is 20 participants are still there. It was some 27, 28 and still they are logged in. So I suggest they all go have food, keep chewing whatever they have learned in their mind and food in the mouth, and have a happy weekend.
Yeah, thank you. Thanks, everybody.
Thanks, everybody. Thank you, Vani ma'am. Thank you, Natesan sir. Thanks, everybody.
Madhu, very good presentation.
Ma'am, thank you very much, ma'am. You made my day. Thanks.
Rahim?
Yes, ma'am. நான் end பண்ணிடுறேன், madam.